I would like to make a very brief picture about mental health. It was very interesting what Guido has explained of his procedure and his clinics. And I would take some of his ideas to picture also what some things that I wanted to explain to you. I would focus mainly on depression. I will say a little bit about anxiety because I will try to show you that depression is the most frequent disorder that's been shown in many studies. But I would say the most of the patients that come to my clinic, they come because of anxiety. Okay, but they will focus on depression because we try to show you that depression is underdiagnosed, and I think that for non-psychiatrists it's good that you know how to detect, how to measure, and how to deal with depression. So we will focus mainly on depression. Okay, this is my hospital clinic here in Barcelona. No, I have no complete interest belonging to this presentation. So these are very few data about prevalences. Unfortunately, most of the data are from studies done in the US. There are some studies in African countries. There is one study done in Holland, but most of the studies are done in the US. So take care of this data, but these are the data that we are. So you see from the first studies, this is a very big study, that most of the patients with psychiatric disorder had mood disorders. Mood disorders are, for example, depression and bipolar disorder, as you can see here. But as you know, maybe for your patients, most of our HIV patients have problems with substance use, which is also very common. There is a relationship between substance use, depression, also psychotic disorder. So it's difficult to distinguish, separate both disorders, mood disorders and substance use. But substance use is still very prevalent in our patients. I could also speak a lot about methamphetamine and so on, which is also a big problem in our countries, and I know in other European countries. So if you look on other places in the world, as I told you, in African countries, you see the very similar data that we can find in US. This is very, very, very strange because most of the studies done with the general population, not with HIV patients, but with general population about depression. So we can see that in patients with, in countries which are more developed countries, you see more rates of depression than in underdeveloped countries. Here you see that the rates, the prevalences are very similar between the developed and undeveloped countries, and yes, as you see from the African studies. So many in many aspects, I will try to show you later, depression in HIV is quite different than depression in the general population. This is also a very interesting study done with interviews, not with looking on charts and so, but interviewing the patients using psychiatric interviews. And here also say that there is a very similarity between men and women, which is also different from the general population. You know that from the general population we see more prevalence of depression in women than in men, but it's not the case in HIV. So this is also an interesting factor that I wanted to point out. Same prevalences, not depending on the social economic level, no differences belonging or not to one gender or the other. And the other thing is, it's also very interesting to point out that depression or psychiatric disorders, generally speaking, are more prevalent than many of the medical problems that our patients have. So therefore, I think, and I will try to explain to you, and one of my conclusions will be that non-psychiatrists, physician or nurses or whichever health provider that work with HIV patients should have some kind of knowledge on how to manage psychiatric problems in their patients, because as you see, these problems are very, very prevalent. And the problem in depression is that, I wanted to explain also the reasons why we can find these high prevalences of psychiatric disorders in HIV. First of all, they are patients with psychiatric disorders, they are very at higher risk of getting psychiatric disorders. We know, getting infected by HIV. We know that bipolar disorder, schizophrenic patients, they are at higher risk of getting infected, not only by HIV, but also Hep C and other infections. So therefore, you can find patients with severe mental illness that have HIV. We also know that getting to know that you are HIV positive can make a depressive reaction, emotional reaction. So it's also very common that after knowing that you are infected, that you get depressed or with a high anxiety. from all the history of your illness, of all the controls, waiting for the lab test. This kind of situations, this kind of events make you also produce an emotional reaction with depression and anxiety. So it's very easy to find this kind of symptoms in our patients. Thirdly, we know that the virus enters the brain, so there could be also some kind of damage. This could be presented in form from also psychiatric symptoms, psychotic symptoms, also depression and so on. And finally, that we know that some of medical problems and also some of the treatments that we use for HIV patients can also produce psychiatric disorders. We know it from efavirenz, we know it from hypothyroidism, that can also produce depression, as you know. So for all these reasons, you can say that it's understandable why psychiatric disorders are so prevalent in HIV patients. And therefore, I think that it's very, very important that HIV physicians, HIV nurses, and so on, should learn how to detect and how to manage psychiatric disorders in their patients. So, and one other factor which I think is very important, and Guido has mentioned it before, that if we do not treat or diagnose and treat properly, then there are a lot of patients who suffer from that, who suffer a lower quality of life because of these problems, but also health costs are higher. So not only by the quality of life of the patients, but to improve health costs, and so we should be very alert, and we should know how to detect and treat psychiatric disorders in HIV patients. So let me speak a little bit about depression, because I said to you it's the most prevalent disorder in most of the studies. Although in my case, most of the patients that they come to my clinic, patients that were sent from the HIV unit, most of them came because of anxiety. So anxiety is also very prevalent. But most of the studies say that depression is the most prevalent disorder. So it's also easy to explain that depression is very important to be treated in HIV patients, because it's very related to some of the bad outcomes factors, like high increase of death, impaired quality of life, decreased adherence to treatment. There are some studies also presented in many of some of the EX guidelines that show that not having depression is related to more loss of adherence to treatment. Of course, there are higher risk behaviors and not having depression. Patients do not care properly if they are depressed, if they are not depressed, and generally they relate it less, they do not have friends, they are more close, they do not have social relationship with other people. So general function general quality of life is impaired because of depression. And in the aspect of cost, medical cost, we also know from many studies that depression in medical patients, but also in HIV patients, are very related to a higher increase of medical and costs. So therefore, it's very important, not only because of the quality of life, not only because of the poor outcome for these patients, but also to improve quality of life. It's important to detect and treat depression. So, but we also know, and I will show you a figure later, a cascade of care of depression and HIV. You will see that depression is underdiagnosed and not treated well. And there are some reasons for that. We know that patients, when they go to the clinic, they do not say, I'm depressed. They do not feel well, and they say, I'm some pain, I feel fatigued, I do not sleep well, and so they do not go to the physician and say, I have a major depression. We have to ask them. Maybe you are right. If you know the patient, and the patient enters the room for the first time, after time, and you see the face looks different, and you may see this is not the patient that I used to see, that you may say, okay, something is happening to that person. And you can, without asking anything, you can see that something is wrong with this in this patient. It is because you know the patient, because you are used to see him well, and suddenly he comes with a different expression. So you can also think that there's something wrong. It could have a depression. But it's difficult sometimes that the physician asks for depression for psychiatric disorders. You said before, using scales is not so useful. It's better to ask the patient. But maybe you have colleagues that do not like to ask emotional things to their patients. This is, I would say, very normal. It's all physicians are very different. Nurses are very different. Some physicians like to ask about personal things to their patients. They like to ask about emotional things to their patients. But other colleagues, they do not like to do it. So maybe to use scales, or not only using scales, but knowing the questions that we have to make. I do not use scales, but I have the questions in my brain, so I use the same as using a scale, but only asking. So the HARTS has only 14 questions. I can remind 14 questions and ask these questions to my patients. I think you also, as general health provider, you can also ask these questions to your patients systematically in every visit without using questionnaires. I think it's very good to check, because otherwise depression, other psychiatric illness will pass without knowing that the patient is like that. So in some cases, there's no time to ask, because if you make 14 questions to a patient asking about anxiety and depression, you will need at least 5-7 minutes. Maybe you have only 10 minutes for your visit, I don't know. So if you want to ask about medical problems, how he's taking the medication, so on and so on, you won't have enough time to ask about emotional things. It could be. But you can give him the scale maybe. He can make the scale at home or with the nurse and can give you the scale, and you only look on the score and say, hey, something is happening to you. So it's very, very fast, and only in 5 minutes you can also get it. And finally, there is a general belief that, okay, having depression in HIV should be very normal because of the stressful things that happens in HIV patients. So it seems that depression is not so important. I show you data about how bad it is because of the poorer outcome and so on and so on. But there's a general common thing that, okay, depression is very normal. Everyone can have bad days and so on and so on, but not to have to treat depression in these patients. And this is wrong, because we see that if we treat depression, the outcome improves, and also quality of life and all these things could be better if we treat it. Not only treat it with medication, but also treat it with psychotherapy. But treating depression is very important. So this is the cascade of care, depression, HIV. So as you see, it's very different from the data presented by Guido before. This is a study done in the US, but you see that depression is underdiagnosed, undertreated, and many of these patients with depression are not in remission. So this is a very thing that we should improve in the next years, not only quality of life, but you see that the depression and also other psychiatric disorders like anxiety and so should be taken more and more account and trying to improve this data that I showed to you. These are very, very bad data, as you see. Okay, but it's not so easy to diagnose depression. Depression is only a list of symptoms. This is the way we diagnose depression, measure depression. Measure depression means you have to have these symptoms. We do not have any lab test, any other kind of test that we can use to diagnose depression. But depression could be because the patient is really a major depression, because the patient has a major psychiatric depression. But it could be also because the patient has suffered from some kind of personal problems in their life. That it happens like the case before, the mother died and he had some other personal problems. This is not a psychiatric disorder. This is only a psychological reaction to some personal events. This is more emotional thing that we have to treat with more psychotherapy than with treatment. But the major depression, the psychiatric depression, should be treated with antidepressant. But if the problem comes because of psychological problems, then we should afford this with more psychotherapy. But we also know that, as I said, the HIV enters the brain. We know that there is an inflammatory reaction. We know that there are also some studies that have shown that increasing inflammatory factors is correlated with increase in depressive symptoms. So some of the patients that we see that refer depressive symptoms could be also because of a brain damage, not only because of major depression, not only because of psychological problems, but because the virus is doing something in the brain, impairing the brain or producing an inflammatory reaction, which could also produce these depressive symptoms. So the treatment will be very different. And also medical conditions, as I told you, hypothyroidism, hypogonadism, this can also produce depressive symptoms, and the way we treat these conditions is not the same we treat depressive, major depression or psychological depression. So we have to treat this, improving the thyroid function and improving testosterone levels, for example. And we also know from some medications that can also produce psychiatric or depressive symptoms, so the way to treat this is very different. For these two last conditions, we should do lab test and try to exclude these conditions to know if the patient has major psychiatric depression. So this will need a more extended psychiatric interview. But in your clinic, you can use simply this kind of lab test to exclude this other more medical condition of depression. This is the things that you have to do, a very simple general lab test with hormone testing, thyroid testing, testosterone and so on, B12 vitamin and so on. In some cases, if the patient says there's some cognitive problems, and so we can do a brain imaging, MRI or CT scan. But generally, if the patient has a normal depressive symptoms, then with this kind of test could be very enough to exclude medical conditions. So let me speak a little bit about anxiety, which is, as I told you, very, very, very prevalent as well. In any case, in my clinic, or the patients that I see. And as in the same way that depression is very prevalent in HIV patients, we also see from some American studies that anxiety disorders are also very prevalent, and it's also very related to the life of these patients. Many of them patients with a long time of having HIV, with a lot of stressful life events, not only because of their personal life, but also stressful life events because of the HIV illness itself. As I told you, going every month or every 2 months to the physician makes them be anxious. To wait for the test makes them be anxious. To have any kind of medical problems, they are thinking, oh, it could be because of my HIV illness, so this makes me very anxious. So everything in their lives, everything that could relate them to a poor outcome of the HIV could make them more anxious. So anxiety is very, very prevalent in our patients. Also changes in treatment, changes in physicians, to change the referent physicians could be that make them more anxious, as you can imagine. In many, many cases, you can see both things, depression and anxiety. In most of the cases, this is because anxiety, when it takes more and more time, it can produce depression as a secondary depression. So a person who suffers of a lot of the anxiety a lot of time can be depressed after that time. And the treatment is very similar than treating the anxiety. If you look on disorders, anxiety disorders, this is maybe very specific for psychiatry. You see that most of the disorders are more prevalent in HIV patients, except from specific phobia. Specific phobia, for example, phobia to animals, phobia to close places, and so on and so on. But most of the anxiety disorders are more prevalent in the HIV patients than the general population. Okay, so and this in the same way that it happened with depression, that we also know in some way that anxiety is also related to poorer outcome, in the sense that patients do adhere less if they are more anxious, and they are more and more at risk of doing risky behaviors, to take substances. So what some studies do not show is that there is no evidence that anxiety is really related to a poorer progression of the HIV illness itself. But it's true that it's very related to the poorer adherence. And again, patients suffer for them, the quality of life and so on is impaired. Okay, so as conclusion, I would say that I would try to show you how important it is that mental problems in people living with HIV/AIDS. That in many cases these are not very properly diagnosed and treated. Mostly in HIV clinics, many patients came through without a diagnosis of their depression, of their anxiety, because they have enough time, because the physician is not prepared for that, and so on. So it's difficult to detect in some cases. We also know that psychiatric patients are at higher risk, so you have to tell your colleagues, your psychiatrists, that they have to do also testing to their patients. This is also a message that I give to my colleagues in psychiatry, that, for example, patients with schizophrenia, patients with bipolar disorder should be tested for HIV, because we know that they are at higher risk of getting infected. And as Guido has told before, collaborative care is necessary, not only between all the HIV health providers, but also with the mental health providers, and also with the primary care physicians. And also continuous education for HIV physicians, but also for psychiatrists working with HIV should be implemented. It should be done in most of your clinics. So thank you very much for your attention.